Hello, and welcome to the TeleEMG online courses series. In this section, we will cover nerve conduction studies in the upper and lower extremities. I'm Dr. Joe Jabre. I'm a neurologist, and I specialize in EMG and nerve conductions. So let's talk about the common conditions that you will probably see to have ordered nerve conduction studies and EMGs for, and their costs. I'm sure you've seen, if you don't have low back pain yourself, I'm sure you've seen or know people who have low back pain. In fact, it's the fifth most common reason for all physician visits in the United States. Its estimated cost, $60 billion a year. Carpal tunnel syndrome. How many people you hear who complain about carpal tunnel syndrome? Quite a few. And it's a major cause of nerve pain and hand weakness. Estimated cost, about $5 billion a year. Diabetes and the neuropathies associated with diabetes. Approximately 60% of diabetics have a neuropathy and its complications. Estimated cost, about $20 billion a year. So, how is pain diagnosed? Well, would you be surprised to learn that 75% of people with low back pain, carpal tunnel syndrome, and diabetic neuropathies end up having EMG and nerve conduction studies? 75% do. And they all have it at one point or another of their life, or during the time or life of their condition. So, how do we do EMGs and nerve conductions? What does it take to do EMG and nerve conductions? Well, here's an EMG machine. It's upside down the way you see it right now, but it's a fully functional EMG machine. And the reason I'm showing it to you this way is I want to show you the electrodes that plug into it. When you look at the electrodes, there's 3 of them that are connected to the EMG machine. There's a green one, and that's the ground. Because you know what? We're going to stimulate patients, give them an electrical stimulus, and record the response of their nerve or muscle of that electrical stimulus. So basically, we're going to, first of all, protect them, and that's the role of the ground. It's green, like all grounds. The second electrode here is the black. So we put this over a nerve or a muscle, and we call that the active recording electrode. The third electrode that you see here is the red one, and that's called the reference electrode. That means that when we record a response from a nerve or a muscle, this electrode is looking at what is this electrode seeing, and I'm going to compare it to that. So if this electrode is seeing nothing, most of the activity that is going to be seen under this electrode. But enough for that about this for now. We'll talk about it more later. Just remember that an EMG machine is connected, or electrodes are connected to the EMG machine, and always we connect 3 electrodes: the ground, the active, and the reference electrode. And that's how we do a study, a nerve conduction study. Now, of course, in order to record something, we have to stimulate the nerve to record something, either from nerve or from muscle. So, let's just show you real quick. What do I mean by that? Here's a stimulator. I'm positioning it over a nerve, and I'm recording from the finger. There's no muscles in the finger. So basically, in this case, I'm recording from nerve. You can see the 3 electrodes that I spoke to you about. The green is the ground. It's put somewhere on the hand in a relatively silent area. This is the black electrode. That means it's right on top of the nerve. This is the red electrode, the reference electrode. That means the activity that is seen between these 2 electrodes. That's the best way to think of it. And the electrical stimulator delivers an electrical shock, which the patient feels as a tingling going down their hand. So this is a sensory study, in this particular case of the median nerve. Now look at this. This is a motor study of the same nerve. We're stimulating the median nerve as well, but now we're recording from muscle. So now we have the black electrode, the active electrode, over muscle, and the reference electrode over the finger of the thumb, meaning over nerve. So now we're comparing these 2 responses to each other, and the ground stays in the same place. It doesn't move very much. Let's look at a typical EMG machine, or a typical EMG machine setting. So first of all, you have the EMG machine. This is it. that I was just talking to you about. Okay, it's connected to a laptop computer. The EMG machine has a stimulating electrode. This is it here in this case, right? And it has recording electrodes. These are recording electrodes that are connected to it. And the EMG machine is connected to a laptop because all the program that's going to run this EMG machine is in the laptop. So basically, you have the EMG machine, you have a laptop computer, you have stimulator, you have electrodes, surface electrodes, and you have needle electrodes, because when you do an EMG study or needle exam, you use a needle. And then you have a cable that connects the electrode to the machine. And of course, when you put something over the skin, you need conductive cream and a tape measure to measure the distance at which you're applying the stimulus, and so forth and so on, to see where have you recorded from and what you stimulated to record from that place, essentially. Now, what can an EMG study add to your practice? First of all, it's an extension of the clinical exam. What that means, if you're examining a patient, you're suspecting something, and you want to find out if it's true or not. So it's an extension of your clinical exam. It shows you that the patient does or does not have it, and in this case, you need to look for something else. If the patient does have what you're suspecting they have, this test is used to document the nerve or muscle involvement, determine the type, the location, and how bad it is, how severe it is. And of course, once you find this, you correlate these symptoms with the clinical findings and what the patient is complaining about. And once you've decided what's wrong with the patient, you can then decide on an appropriate treatment and referral, if needed, to a specialist. And of course, if you institute a treatment, you need to do follow-up studies to find out if this treatment is working or not working. So let's start with what we tell the patient about what this study is about. I think it's always very important to make sure that the patient understands what this study is about before starting the study. I think that's very important because, let's face it, when you feel an electrical stimulus in your hand or in your foot, your arm, or your leg, you're going to jump. So if you explain to the patient that's not going to harm them, that it's going to be very, very brief, and that's going to tell us what's wrong or what's not wrong with the study, then they're more likely to be cooperative with you. Same thing with the needle exam. You're going to tell them that you're going to stick a needle in their muscle, but you're not going to stimulate them with electricity while the needle is there. And two, you're not going to inject anything or draw anything out of that needle. So I think it's always very important to explain to the patient prior to doing the study what you're going to be doing to them. Now, I did say a few minutes ago that we do two types of study. One, sensory nerve conductions, and the other is motor nerve conductions. What does that mean? That means when you stimulate a nerve, generally speaking, most nerves have a sensory nerve inside of them and a motor nerve. So the nerve is sort of a little circle tube that has sensory and motor fibers inside. So when I'm stimulating a nerve here, I'm stimulating both the sensory and motor fibers, not just the sensory or just the motor fibers. But if I'm putting the surface electrode, what I need to record from, over the muscle, like so, I will be just recording from the motor fibers. If, on the other hand, I'm putting the electrode over a finger, I'll be recording from the sensory fibers. So in this case, like here, when you stimulate over the sensory fibers, the nerve here, right here, and you put the recording electrode over the sensory fibers, you're going to get a sensory response. And this is what a typical sensory response looks like. Now, here's what I want to show you in this particular setting. You see this sharp takeoff here, wave form? We call that the shock artifact. What does that mean? That means the machine is sensing that you delivered an electrical shock, and it's going to show you what the electrical shock looks like. All right? But then this is really the nerve response. In this case, this is a sensory nerve. Okay? That means we stimulate the nerve at one point, and we record from nerve. Okay, like here. You stimulate the nerve, and you record from nerve. Okay? So this is the response. So we know that this started right here. Okay, because that's when electricity was delivered. But look here. This is how long it took from here to here for us to obtain a nerve response. It traveled this distance before we could see the nerve reacting to it. So you see O, P, T, and R here. You know what that means? Is this O means it's the onset of the nerve response. Okay? So the distance between here and the O is the time it took for the electricity to travel from one point to another to reach the nerve. Because it's a distal distance, that means far from the nerve, we call it distal latency. Distal latency means how long did it take to travel from this point to this point. Then P here is the peak of the response because it's the tip of the response. That's the peak. Okay, T is the trough, and R is return to baseline. And then when you stop the stimulation, we stop the stimulation here. It becomes flat. And here it says that we stimulated at the wrist. We got a response from the nerve. You can see the O, P, T, and R. Okay, and that's a nice sensory response from the median nerve. Now, what do we measure with that? We measure the amplitude. Well, how big is this response? Let's talk electricity. If you have a wire, and that wire has electrical cable, and that cable has electrical wires inside of it, it can have 10 wires. It can have 20. It can have 5. You guessed it. If you have 5, you're going to get a small response. If you have 10, you're going to get a bigger response. If you have 20, you're going to get a bigger response. So basically, how many wires or axon are inside that nerve is going to determine the amplitude, the size of that nerve. Okay, so we measure the amplitude. In the sensory nerves, amplitude is fairly small. It's in microvolt. Now, what else do we measure? We measure the distal latency, the time that it takes from here to here, distal. Or we also measure the peak latency, the time that it takes from here to the peak, essentially. Why? I'll explain later, but just very quickly. In some sensory nerves, we don't see the O very easily, but we always see the P very well. So basically, we say, well, if we don't see the O, we measure the latency from the P, and that's called the peak latency. It's measured in milliseconds. And then we measure the conduction velocity. What is that? Well, you can guess that if I stimulate from here to here, okay, it's going to take a certain time to go from here to here. If I stimulate from here to there, it's going to take longer. And if I stimulate up further, it's going to take longer. So basically, I have to relate the time that it took to the distance that I used. Okay, and when I divide the distance by the distal or the peak latency, namely the time, I'm going to get a conduction velocity, which is expressed in meters per second. So that's what this looks like. See this red thing here? That's the normal values. In other words, I'm going to compare what I found here in amplitude, in latency, and in conduction velocity to those obtained in normal individuals. And that's how I know if what I recorded is normal or abnormal. Now, for the motor conductions, same thing as the sensory conductions. We stimulate a nerve, but now we record from muscle, in this case from the ulnar nerve. In motor conductions, we stimulate 2 or 3 points. In sensory conductions, generally speaking, we only stimulate 1 or 2 point stops, but most of the time 1 point. But in motor conductions, we stimulate 2 or 3 points. We calculate conduction velocity between these 2 or 3 points. And more importantly, we record from muscle, not from nerve. Now you see here the O, you don't see the stimulus artifact, but it's obstructed here. But the time that it took for this is the stimulation from the wrist. Now we stimulate below the elbow for the ulnar nerve. Look, the O is further down. Why? It's crossing a much longer distance. Then we stimulate above the elbow. The O is even further. So now when we divide the difference between this O and this O, and divide it by that distance, we get the conduction velocity from below the elbow to the wrist. When we calculate the difference between this O and this O, we get the latency from below to above elbow, and when we divide it by this distance, we get the conduction velocity from above to below elbow. So here, like in the sensory, we measure the amplitude. Instead of microvolt, we use millivolts because the motor amplitude is much greater than the sensory amplitude. We still measure the distal latency, The proximal latency, this is the distal, this is proximal latency. And we calculate the conduction velocity between these different points. Always, as usual, compare it to normal values, obtained at the same stimulation and same recording points. It's very important, because otherwise you'll be comparing apples to oranges. Now, there are two other things that we measure. One is the F wave, and the other is the H-reflex. The H-reflex is in the lower extremity only, but the F wave is in the upper and lower extremities. Now, let me go back one slide here. You see that when we studied here, I'm studying the nerve between here and the hand, or between the elbow and the hand. What about that segment above that goes to the neck? Are we able to study that? And the answer is yes, we're able to study it with the F wave. Okay? Now, when we stimulate a nerve here, okay, right there, you're going to stimulate the nerve, deliver electricity that goes this way to the muscle, but also you're sending electricity up to the spine, to the spinal cord. Okay? And the spinal cord is going to react to that and send this reaction back to the muscle. Only the time it takes to travel from here to here is much shorter than the time that it takes to travel from here up the spinal cord and comes back. So that response is going to be very delayed. An F wave is called a late wave, essentially, or a late response. So basically, we're not going to see it too close to this motor wave. We call that the M wave, because it stands for motor wave. This is what we have seen before as the motor wave. Look at the F wave as much smaller and a much greater distance, okay, because it's got up to the spinal cord and come back. And that's very useful because it tells us if you have a disc disease at the spinal cord level, or a compression, or a lesion, or an injury, whatever. It gives us more information than just to look at this section of the nerve, essentially. And that is the F wave. And for the F wave, we stimulate the nerve at one point and we record from the muscle. We measure the latency, in other words, the distance from the stimulus artifact here, shock artifact here to here. And you guessed it, because a tall individual is going to take much longer to go up and down the spine, whereas a shorter individual is going to take much less time to go up and down. So we always relate that to height. And that's the F wave. So in the upper extremity, we study sensory and motor nerves and the F wave and three nerves. We study those in the median nerve, in the ulnar nerve, and in the radial nerve. Of course, there's more nerves, but these are the nerves that we routinely study. In the median nerve, we study routinely the sensory fibers, the motor fibers, and the F wave. In the ulnar nerve, we also study the sensory fibers, the motor fibers, and the F wave. In the radial nerve, routinely, we only study the sensory fibers. Now, here's the median sensory response. We stimulate the median nerve at the wrist. We stimulate it at 13 centimeters from the black active recording surface electrode. Why is that? Because we have found normal values for this distance. You could do it at 15 or 16 or at 11. If you have good normal values for this distances, that's fine. So basically, we stimulate the nerve here, put the active electrode on the index finger, the reference electrode slightly below it or further down from it, and the ground is here. And you've already seen that. The takeoff is, the shock artifact is here. The takeoff or onset is here. The peak is there. The trough and return to baseline are there. And what do we do there? We divide the distance, 13 centimeters, by the latency, onset or peak, and calculate a conduction velocity. And that's the median sensory response. For the ulnar sensory, we do the same thing, except that we put it over where the ulnar nerve is, namely over the fifth finger, the baby finger. Now here we use 11 centimeters, again, because we have good normal values for this distance. And we get a waveform, looks exactly like the median sensory waveform, but has different normal values. And we compare it to the normal value table that we have here, and we calculate conduction velocities. And that's the ulnar sensory response. Now for the radial nerve, we put the electrode right here between the index and middle finger in that hole here, essentially really in this hole right there, as you can see, and stimulate the nerve over the forearm, okay, over the radius bone at 10 centimeter distance. And so we put the active electrode here, the reference over the thumb, and you can barely see the ground here. And that's the response that we get. And we compare it to normal values. And that's the radial sensory response. Now that we've done all the sensory responses, we go to the median motor response. And here you see that we put the stimulator over the median nerve, same place as the sensory, because that nerve at that point has sensory and motor fibers, just like we said, in the same nerve. Okay, but now instead of putting the electrode over the finger, the active electrode over the finger, we put it over the muscle. Okay, so we're stimulating the nerve at the muscle here, and we're stimulating the nerve at the wrist here, records from a muscle, and then we do the reference electrode still at the thumb, and we have the ground electrode right there. Okay, and we get a very nice motor response here from the wrist. Again, you see the onset, the peak, and the return to baseline, and compare it to normal values. By the way, in motor studies, you will very easily see the onset. In sensory studies, in most cases you do, but not in all cases. So therefore, in sensory studies, we could use either the onset or the peak latency. In the motor studies, we only use the distal latency and the proximal latency. The ulnar nerve, we study it at the wrist, below elbow and above elbow. Why at the elbow? The median nerve doesn't really normally, or in most cases, never get entrapped at the elbow. There are few exceptions to that. But the ulnar nerve does. If you're doing like me, namely leaning on your elbows right now, you're going to compromise your ulnar nerve at the elbow. So that's why we always study the ulnar nerve at the elbow. And here we're stimulating the ulnar nerve at the wrist. You can see here. Then we put the active electrode over the abductor digiti minimi muscle. That is this muscle right there. Okay, which does this. It actually spreads the baby finger. Okay, and record from for the reference electrode from the baby finger. Okay, and here's the response that we get. Then we stimulate the ulnar nerve below the elbow. I usually use a distance of 3 centimeters below the elbow and above the elbow at a distance of 9 centimeters for a combined above to below elbow distance of 12 centimeters. And look, we get this response here, O, P, onset, peak, and trough, and return to baseline. This is from the wrist. From below elbow, it's further down because it's longer distance. From above elbow, it's even further. And now we do conduction velocity in those between the wrist and below elbow and above elbow. If you have an ulnar neuropathy, 9 times out of 10, it's going to be between this response and that response, between the above and below elbow. So, now we're going to come to the lower extremity. The principles of sensory and motors are the same. They also have F responses, but in addition, they have the H-Reflex, and I'll tell you a bit more about it. So, sensory nerve conductions, you stimulate the nerve at one point and record from nerve. You also measure the amplitude, the distal or peak latency, and the conduction velocity. Here I'm showing you for the superficial peroneal nerve, not easy to see, but I'll show it to you a better way in a couple of minutes. And you're recording from a sensory nerve in front of the ankle bone here, the anterior, the malleolus. And so basically you measure again the same parameters that we said in the upper extremity. And you can use either the onset or the peak latency or trough and return to baseline. Now for the motor nerves, exactly like the upper extremity, you measure the amplitude, the distal latency, and conduction velocity. This is showing for the peroneal nerve, where we stimulate at the ankle and records from the extensor digitorum brevis muscle, the muscle that lifts the toes up, basically like so, backwards. And then below and above the knee. The reason for that is like the ulnar nerve, if it's going to get damaged, it's going to get damaged either above or below the knee. From crossing your legs or from hitting your nerve right at the knee level. So here you see from stimulating at the ankle, this is the motor response, O, P, and T. This is below the knee, and it's actually called the fibular head, because the fibula bone, and it has a head, and the nerve gets compressed right at that point, right at the fibular head. So we call it below the fibular head, below fib here, and above the fibular head. The fibular head is right here. And you can see how the O has now moved and moves further. So we can calculate the conduction velocity between this point and that point, and another conduction velocity between this point and that point. And then for the motor conductions, we do F wave for the peroneal nerve, and the F wave is done with the stimulation at the ankle as well, and we measure the late. So we're stimulating here, you're getting a motor response, which is an M wave here, and you have another electrical stimulus pulse that goes up to the spinal cord and comes back and gives you a small response here, the F wave. See how long it took to get there? That's the F wave. Okay, we do it like in the upper extremity. We measure its latency, and we measure and we correlate it to height, obviously, because taller people would take longer to get up to the spinal cord, shorter people would take less time. So you have to correlate it to height. And in this case, finally, we measure the H-Reflex, and we measure that from stimulating the sensory nerve here as opposed to the motor nerve. The sensory nerve goes up all the way to the spinal cord, connects with the motor nerve here, and generates a reflex. Now that takes very long to go from up here to down here. And as you can see, the reflex is a nice motor response. It's very big here. It's very late because it took a long time to go from here to here. This is the H-reflex. We see it in the leg, not in the arm. And this is the beginning of the motor wave that came from stimulation here. Again, in this case, we measure the latency and we relate it to height. Now, let's see real measures of the sensory nerves that we study in the lower extremity. We study the superficial peroneal nerve, which is a branch of the peroneal nerve, but it's a sensory nerve of the peroneal nerve. We stimulate it right above the fibula here, okay, at 12 centimeter from the recording point, from the black electrode, active electrode, which we put in front of the malleolus. So we put the active electrode right here in front of the malleolus, above the malleolus. We put the reference electrode below it, next to it, and here's the ground, and we'll use 12 centimeters. And again, this is a nice sensory response that you see O, P, T, and R, and here you calculate the distal latency or the peak latency, and then you divide the distance by these latencies, and you get a conduction velocity. That's the superficial peroneal nerve. Now, we also do in the lower extremity the sural nerve. The sural nerve is behind the malleolus. The superficial peroneal nerve was in front of the malleolus. The sural nerve is behind the malleolus. And we stimulate in the back of the calf at a distance of 14 centimeters above this surface electrode. And you get a very nice sensory response, O, P, T, and R. Again, you calculate distal, peak latency, trough, return to baseline, and then divide the distance by that and get a conduction velocity. Then we start studying motor nerves in the lower extremity, and the first motor nerve that we study, as I was telling you, is the peroneal nerve that we stimulate at the ankle. We stimulate the peroneal right here in front of the ankle bone, and we record from the extensor digitorum brevis muscle. That's the muscle that brings the toes upwards, okay? And it's in this area of the foot. So that's where we put the black active electrode, and we put the reference electrode rather below it, and you see the ground here. Then we stimulate the peroneal nerve also below the fibular head and above the fibular head at the knee, essentially. And the distance we use between these two is 10 centimeters. Again, because we have good normal values for that. Now you see the three responses: the ankle below the fibular head, above the fibular head. One is O, onset, peak, and trough, return to baseline. The O is getting further and further and further. We calculate velocities, conduction between the ankle and the below fibular head, and between below fibular head and above fibular head. So we stimulate this motor nerve, the peroneal nerve, in 3 different places. Now, for the tibial nerve, we stimulate it at the ankle also, and usually there's very few areas in where the tibial nerve can get damaged at the knee, so we only stimulate it at the ankle, and we put the active electrode here right below the ball of the foot over the abductor hallucis muscle. That's the muscle that spreads the toes, okay? And we stimulate the nerve at the ankle at a 14 centimeter distance above that. And we put the reference electrode over the ball of the foot, essentially, and you can see the ground. And we measure a nice motor response with O, P, and T. And in this case, we just calculate the distal latency. And that's the median motor nerve. Then, the H-reflex, this is how we record. We have the subject lay down on their belly. We stimulate the tibial nerve right at the knee. And we record from the calf muscles right there. I ask the subjects to bend their foot like so, and I find the V that these 2 calf muscles, gastrocnemius muscles, make, and I put this active black electrode over the V and the red reference electrode right below it. And here you see a very nice H-reflex. And obviously, like the F-wave, it depends on height. And these are the conductions in the lower extremity. So, now, to finish up, you can see a lot of these pictures and a lot of these techniques explained on our webpage on www.teleemg.com. And also, we give courses on almost a monthly basis. You can sign up at our webpage also. These are 2 days intensive hands-on courses with lectures and training and hands-on exercises for people wanting to learn how to do nerve conduction studies. And we give you a lot of training material, manuals, DVDs, and so forth and so on, and show you how to use these. Also, on our webpage, you can find DVDs for nerve conduction studies, and for needle exam, they're about 1 hour each, and go over all the details and show you the technique of how you do nerve conduction and needle exam. So thank you very much. I hope that this has been helpful to you, and we hope to see you again in the future, either on the webpage or in these TeleEMG online courses. Thank you.